we can get to know each other and build relationships. So we're here as a result of some amazing funders, including the Minnesota Department of Health and the Copic Medical Foundation. The work is supported by Got Transition, Project Echo, and Gillette Children's, where I work. We're here to transform pediatric to adult healthcare transition in Minnesota. Next slide. So our aim is to not only transform transition from pediatric to adult care, but also to ensure that it is equitable, accessible, and trauma-informed. Next slide. Again, our funders, we couldn't do this work without them. Next slide. Core faculty who you will see throughout the discussion today. A couple of us from Gillette, from Got Transition, Minnesota Department of Health, and mHealth Fairview, as well as our lived experience expert. And we have a much larger steering work group drawing upon the expertise across the state of Minnesota. You can find everyone's bios on our Healthcare Learning Transition Collaborative for more details. This does count for CME. You get an hour. There will be an email following today's session for how you collect that CME. Next. And again, it's good for 1 hour. Next. We want to make this as interactive as possible. So use your video, mute unless you're speaking. If you ask a question, you can raise your hand. You can put it in the chat. I'll be monitoring those. And if you are coming off chat, just an introduction of who you are and where you come from would be excellent. Excellent. So the structure of our echo session is a little bit different. Normally we do a didactic and then a case. Today we are so fortunate to have 3 separate cases, which will be peppered in. We'll have about 10 minutes of discussion for each case, and then we'll wrap at the end of the session. We want more cases. So if you have a transition-related problem, either with developing your program or a specific case or question, we would love for you to be able to utilize this resource of 90+ people, multidisciplinary across the US, to kind of toy through how you might think about that problem or difficult situation in a new way. So you can, scan the QR code. Literally, it's a couple of sentences. You present for all of 2 minutes, and then you get to just listen to this great hive of people together reflecting on how that case could be thought differently or some great ideas. Next. We are not developing any patient relationships here. So with no further ado, I get to introduce Dr. Chris Hanks, who is coming to us from the Ohio State University Wexner Medical Center, where he is a med-peds physician and cares for patients across the lifespan. He has a special interest in caring for adult patients with autism on the autism spectrum, as well as integrating them seamlessly into his clinic. So with no further ado, join me in welcoming Dr. Hanks. Thank you.
Thank you, Tori. I saw in the chat a lot of people chiming in on where and who you're from. And Tori, I don't know if you saw, but Patience looks like she's having a hard time getting on. So thanks for posting that. It actually helps me to kind of get a feel for who our audience is. I see a wide range of people. I was asked to talk, and I'm going to want sharing my screen. I'm going to try and talk, which is always tricky. But are you seeing just my slides, or do you see my Zoom screen if I pull it over there?
Right now, I just see you.
Oh, I failed. What else is new, right? All right, there we go. Now you see my slides? Excellent. That's what we need. Okay, so I was asked to talk about working with young adults with intellectual developmental disabilities, really more focused on the adult outpatient practice. Obviously, as I'm watching the chat while people were joining there, Many of you work in pediatric settings, or kind of work in settings that span between pediatric and adult healthcare. I think one of the challenges we've experienced over many years of thinking about transition is that, the experiences on the pediatric side and the experiences on the adult side are different for patients and for providers. And so I'm going to go ahead and try and talk a little bit about the adult experience, but the cases we're going to talk about are young adults that could realistically be seen in either setting, depending on the system. So with that in mind, let's see if I can make things progress properly. Maybe. Hang on. There we go. So we're going to talk about employing strategies for how to prepare your office and staff, for young adults with IDD as compared to young adults without IDD. Talk about what you can do before a visit to help make the first visit go better, and also talk about what you can do during and after visits to kind of make future experiences better. I chose to list these resources first, and we can always share them in the chat later. But this is just a variety of resources, some of which you may be aware of. These first two are tip sheets that myself and Carl Cooley helped Transition develop, that are available, have some nice kind of ideas on how to incorporate patients into your practice, as well as some other nice resources that I may kind of reference as we go along here. A bit about me and how and the program I work in. So as Tori said, I work at the Ohio State University, but and I'm a primary care doctor, but started and run what's called the Center for Autism Services and Transition, which is a primary care based program focused on improving care for autistic adults. We've seen over 1,000 autistic adults in the last 10 years. We now are at 4 different practice sites, and I think as we've expanded to different practice sites, that's given us the chance to discover what works, what easily kind of transfers from one place to another, and what sometimes is more difficult in different settings. And one of I think the most important things we do is we do an intake of our patients before they're seen, so we can kind of learn from their past healthcare experiences and barriers and plan to accommodate for them. And we'll talk a lot about that as we go here. So with that in mind, my plan, as was mentioned, is to do a case-based discussion. And then I'm really going to, with each case, going to stop and kind of talk about these 4 major areas of pre-visit planning, how to feel comfortable both for yourself and for the patient. And then also, how to kind of progress things forward with them. And after a visit, how to kind of plan for the next, for what's next. And so that's, but I should note that I'm going to provide ideas of what to do, but implementation of this really is going to be individualized for each setting. And many of you that aren't in health, aren't specifically in healthcare may kind of look at this from another lens, but I can tell you that I've had many people outside of the, core healthcare team be really helpful with my patient care over the years. So I think many of you, I saw lots of school health nurses and transition coordinators and different things in there. And I think this is very relevant to those groups as well. So with that in mind, we're going to dive into our first case. So this is a case of Emily. She's a 20, and I should say before I start, all of these cases are fabricated. None of these are based on real patients, although they're all based on kind of themes I've experienced over the years. So I'm not sharing any specific patient health information during this conversation. But Emily is a 21-year-old female with intellectual disability and epilepsy. She established care with you last year, but your visits with her have been limited by her behavioral challenges. Every time she comes in, she becomes upset. She starts yelling and screaming and engages in self-injurious behavior, including biting her arms near the wrist and striking herself in the head repeatedly. She has limited verbal language ability and does not consistently answer your questions. You've not been able to obtain vitals, and your examination has been very limited because she doesn't allow you to touch her without becoming upset. She uses a augmentative and alternative communication device intermittently to request certain needs, such as food and water, but mostly has non-word vocalizations and kind of grabs and pulls people to indicate what she wants. She's wearing a helmet, which she wears regularly to protect her head from both the self-injurious behavior and falls related to her seizure. Emily's mother is her legal guardian, but she also follows with a psychiatrist for some behavioral med management and a neurologist for epilepsy. So I present this case as our first case because I think this kind of case is the case that tends to lead to people realizing, wow, we need to do something different, or we're not sure what to do, or a lot of questions. And I get a lot of people reaching out to me with cases like this saying, oh, what should we do? And these are hard. I mean, if we're honest, if you look at this from different perspectives, you might say, well, gosh, this is someone we want to provide good care for, but also you have concerns about, can you keep your staff safe? Do you have to worry about harm to people in your office? And am I even going to be able to help this patient? And so I want to kind of talk about, well, what can we do to help this patient, and what can we do to help patients like this have better visits and better experiences? This is meant to be somewhat of an interactive experience, so I would love anyone that has thoughts, either in the chat or unmuting and verbally, just commenting any thoughts or ideas of what you could do for a person like this.
Great. Thank you, Chris. This is Patience. I'm going to try to keep us all on time today. So please raise your hand, or just, there you go. Arjun, please give us your thoughts. Thanks.
I'm curious for a patient like this, and I should say, Arjun Kataria, I'm not clinically trained. I work at UHC as a product manager. For a patient like this, would like a telehealth visit be potentially a good opportunity, so they are still kind of in their home environment?
So absolutely, that's one way to think about it. Right now, there are some things that we can't do through telehealth, obviously, but absolutely, I think that's one. When I'm going to shift to my next slide while we're talking here. But when we talk, if I can get my slides to advance, I don't know why they decided to stop. Whoops, too far. There we go. But yeah, I mean, when you think about how do you make the patient comfortable? Well, are they more comfortable at home, and can we have a much better experience that way? In some cases that can be really useful. I do still think with pretty much all patients, at some point you're going to want to be able to do some things in the office, but 100%, I use telehealth a lot with these patients, and families really appreciate that.
Great, thanks. Other ideas?
I see a hand raised from Leslie.
Yes, so I come from pediatric background, but are there services like Child Life for adult patients like this?
Great question. Not in my institution, and I'm not aware of other institutions with it. But I do think when you say, oh, I come from pediatric background, when you think about this patient's care, obviously she's 21, I think is what my case said. So she's had a lot of experience in pediatric healthcare somewhere or other, right? And so one of the first things I would do in this case, when we think about pre-visit planning or about helping them feel comfortable, is dig into, like, well, what's happened during their pediatric care? Did she do okay, in prior settings? And if so, what was done? And in this case, if you ask about that, you discover, yeah, actually, she did okay at her pediatrician's office, but they had plans. They made sure that she didn't have to wait, kept the visits really short, and then she was given a reward at the end. And so they'd kind of built a plan in place, right? And that's kind of what you're talking about with Child Life, is like, how do you make this a more desirable experience? And so those are all things that, had we done some proper pre-visit planning for this patient, or if we were for the future, we could say, like, well, how can we recreate those in our setting? Dawn, I see a hand raised.
Hello. I think one of the things we don't utilize enough is desensitization in the hospital and clinic settings. I'm finding that there are oftentimes challenges with things like blood draws and so on. And if we would take the time and try ahead of time to get people desensitized, I think we would find it easier to do the care.
So I think this is a really important point, and this could come up in any of the cases I'm about to talk about. And I completely agree. So obviously we're a long ways from getting a blood draw on this patient right now. And in a future case that we'll talk about in a bit, we'll talk more on that topic. But yeah, and the reality is many of these patients have had negative healthcare experiences. And those negative healthcare experiences make them more anxious and less willing to cooperate in a setting, right? So how do going through my rubric here, pre-visit planning, could we have planned for this better? Of course we could have, or could we plan for a future one by saying, how do we make this work? But then how do you make them feel comfortable? And a lot of that is what you're describing of desensitization, and how can we make this a good experience? So you take past experience and say, oh, at the pediatrician, this worked. So let's plan to have her first visit of the day. We're going to get her in quick, and then what can we provide for that reward? Ask mom or someone else what would kind of help her feel comfortable and feel like it's successful. And the first visit in a patient like this, I'm likely to spend a brief time in the room, do what I can, and then depending on how they're reacting, say, all right, we've had a good visit. Let's get you back again. We'll see you later. Here's your good job reward or whatever that may be for that person, and move on. Not even thinking about, boy, she's behind on vaccines, and man, I'd love to get labs and all these things, because if I make it a negative experience on that first visit, the next visit's going to be harder. But if I have 2 or 3 good visits, then I might be able to start introducing something. And if it's not every single time they come, then it may not be as big of a barrier. I also have, since we're talking about labs, I have patients that their families will not do labs in my office because they don't want that individual to associate that negative experience with the location of my office. And so we'll do everything else in my office and then have them do labs elsewhere. So it's individualized, but you're right.
Yeah. Tori asked for the pre-visit planning to use a form or anything to gather some of this information from families.
Yeah, so we're in Epic, and in Epic you can create, smart phrases that kind of, walk through. So we've modified it multiple times, and I could, after this, I can dig up the publication where I shared what our form was at the time we did that publication. It's old now, it's changed, but yeah, I mean, we made it up, and really, what do we ask? We ask, what are the challenges you're going to experience? Are there things we can do to make it better? Do you have any ideas on how it can help you? And then from there, it's individualized. As I said, we now are operating in 4 different office settings. Mine is a small office where you walk right in and the registration desk is there, and then you're back to the room in minutes. But several of the clinics we work out of are in, big health centers with, you check in at the first registration desk, and then you go up and then you check in at the next registration. It's like this, iterative process. And we've had to redesign for each one. But in any of those, if you have good conversations with people, you can say like, all right, we do a lot of what we just described. We'll put on the rooming processes, like this is a room immediately patient. So they bypass the waiting room, they go straight into an exam room, and that's where they wait, or something like that. So yeah, that was a soft answer to the question of, do I have a form? We do, but it's kind of, it evolves on a regular basis. But the main gist of it is what's worked in the past, or what's not going to work for you. And we'll talk more about what's not going to work for you in another case here in a minute too.
Great. Thank you, Chris. Any other questions?
Oh, this is Betsy Hayes. I'm a general pediatrician in Oakland, California. For some of my patients like this, it is necessary to give 0.5 or 1 milligram of Ativan to get like a lab draw, come into the office. So I see psychiatry. So always, in conjunction with them or talking to them about what they think, it can be very helpful as well.
Yeah, I think, I also at times use pre-medications for things like that. Obviously, if we can go without them, we're happy to not use them. I also have found that some people are so anxious, especially with needles, that regardless of how much you give them, aside from full sedation, that that their anxiety will overcome that medicine. So it's really variable, but it is reasonable to try a benzo, in kind of settings like that as one option. You're right.
Great.
I see a question in the chat here.
Yeah, do you want me to read it? It's when you have an adult show up that is really not able to collaborate, consent sign, etc., but parents have opted not to pursue legal guardianship, do you proceed, send them off to get legal guardianship, or how do you support them, in your opinion? And the individual, I can't read this, individual is not appropriate for supported decision making, really needs guardianship.
So I think you bring up, you know, this could be an entire different talk in and of itself, and I don't know if it is one in this series or not, but supported decision-making and guardianship, I think there are a lot of opinions on this. In a listserv I'm on of a bunch of adult healthcare providers that care for adults with developmental disabilities lately, we had a very heated discussion about this topic, with some people suggesting that no one needs guardianship, because supportive decision making should be, you know, in other ways should be sufficient, and others feeling strongly otherwise. I think historically in the United States, we have utilized guardianship as our kind of preferred method, but there's a shift towards recognizing that many people probably don't truly need a guardianship, and that can be overly restrictive for some. That doesn't answer the direct question. Number one is obviously, you know, regardless if they need help, they should have some sort of, you know, if they need help in decision making, then that should be delineated in my mind. Does that need to be guardianship? Not necessarily. If someone showed up that did not have a legal guardian assigned, but was not able to verbalize their wants and needs, I would still see the patient, and I would engage whoever came with them as best possible. But I think you know, that should be a trigger to explore what's the long-term plan here, you know, of how are we going to have, you know, how are we all going to feel comfortable with, who do I communicate afterwards, you know, in between visits, can I talk to this person that came in with you or not? So it is complicated. And the ideal situation is this is addressed in the pediatric setting before they turn 18, but we all know that isn't always the case. And so, and yeah, young adults that need guardians, but parents are undocumented and can't get legal guardianship is another one of those very gray spaces. I think when you look at, I don't know about the exact legality of this, but you know, at least in Ohio, every state does this differently. In Ohio, for a power of attorney, it can be signed and witnessed by a friend or a neighbor or, you know, your doctor or whatever, and is a legally binding document. And so you don't necessarily need, you know, something gone through the court system to, you know, if the individual signs it and it's witnessed, then you're good to go with that, and that can last their entire life unless they choose to, you know, change it. And I see Anita put a comment in here that parents are default surrogate decision makers. Yeah, I mean, so she's right in that parents are the default surrogate decision makers if they are present, but that kind of begs the question, and Don, thank you, it may not be in every state, but it also begs the question of, are we you know, how do you determine this person needs a surrogate decision maker? Just because they can't verbally communicate does not mean they need a surrogate decision maker. So this is we're getting into the weeds a little bit, and I respect this, and I don't want to go down this rabbit hole too deep, but I do think this is a really important point, that in the case where you're looking at someone saying, gosh, I'm not sure about this, does this person need a guardian or a surrogate decision maker? That's when I start engaging with, like, let's get, you know, do you have a recent psychological evaluation? Did you, you know, can I get your, if they're still in the school system, can I get your last ETR, which provides a lot of kind of diagnostic information, and see, or have you undergone a, you know, an updated diagnostic evaluation to kind of get a sense for what are your abilities and decide the right thing. Because I don't know that this is something that you know, that most doctors feel confident digging through the heavy depths of. So with that in mind, I'm gonna leave that topic from now, but I think we can definitely revisit it as we go along. I think.
Right.
How's my time? Patience? Do I need
We have to
move?
go on to the next case.
Okay. Before I go on to the next case, I'm going to say two more quick things. I think being creative in these situations can be really helpful. I have patients that I've seen in their cars out front. I have patients that, you know, as was mentioned before, I'll see with telehealth. I also have patients that come in, I will examine them quickly, and then they will leave. And then I will sit down and talk to the family. Or I have patients that the family will send me the entire history of what they want to talk about through a patient portal message the day before a visit. And then that allows me to just kind of focus on the patient, get them in and out quick. So sometimes you just have to be creative on how to approach. And now I'm over time and patience is saying, let's move on.
Yes.
So I appreciate all the chats. You know, I'll try and hit as many as I can. And once again, there we go. So case number 2. So this is a case of Alan, a 19-year-old male. He presents to established care. He's accompanied by his mother. You don't have any prior records from his pediatrician. And when he shows up, he's got his earbuds in his ears. He's looking at his phone like this. And you ask him questions and he kind of stays looking there and just answers very briefly with often kind of one-word answers. You learn that he graduated from high school and he's attending a community college. His grades are, quote, okay. He's not currently employed. He did have a job at a local grocery store last year, but he was fired. And he says that he was fired because, quote, they were stupid. Further questioning leads to him and his mom arguing about this, whether it was his fault or not, or his boss's fault. And this becomes pretty heated. And so you're getting uncomfortable. You try and steer back to medical stuff. And his mother answers most of the questions. You keep asking Alan and she keeps answering. And as this goes on, Alan gets, more and more engaged in his phone, starts laying down. He's kind of laying down, looking at the ceiling at his phone and really not engaging with you. She mentions that he has a diagnosis of autism, anxiety, and OCD. He's on a couple medicines for anxiety and OCD. And she says these have been helpful, but then he, when you ask him, he reports that they don't help and he stopped taking them, which surprises mom, who then starts scolding him. And we get into this heated interaction again. When you examine him, he avoids eye contact. He kind of squirms away from you whenever you touch him. And during discussion and exam, he asks several times, "Are we done? What else are you going to do to me?" And he seems pretty anxious. So very different case than the last one we talked about. But I guess let's start with kind of, what have we learned about this patient from this interaction, and what do we want to think about next? So any comments or thoughts on this one?
I have a question.
Yes.
Maybe relates to this case, or maybe just a general question. At what point is it appropriate to separate that young person from their parent?
So great question. And that is a key part of this conversation of this case, right? Is should we ask mom to step out? I think Betsy says get rid of mom. So obviously this is a fraught relationship right now, right? I think you look at this case and you can see this is an intellectually able or intelligent individual. He's graduated high school, he's attending college, and when he's engaging with mom, he seems fairly verbally, competent. When he's engaging with you, he's not giving you much. Mom is clearly highly involved. Their push-pull of their relationship and the dependence and interdependence of these two is challenging. And so, the first question to me, which comes back to what you asked, is why is this patient not engaged, right? Is this patient not engaged in this conversation because he doesn't want to be there? And he was dragged here by his mom? Is he disengaged because his mom has always been kind of taking control? And so he's like, whatever, if she's going to do it, I'm going to peace out. Is mom taking over because he really struggles to communicate certain things, especially when he's stressed, which does happen. There are individuals that when they're stressed just don't communicate well. Or is there something in this office or environment that's upsetting him? So how would I approach this, going back to your question about mom? I would, the first thing I would say is, in the ideal world, it would have been nice to know pre-visit wise, like, oh, well, what's coming in and what kind of accommodations might he need, so we can plan for that. And I'll come back to that. But I do think in this situation, if you can't redirect things enough to get mom and, to allow the patient to engage more, then often the answer is, I would like to spend some time with you alone in the room. Is that okay? And I think that wording says, like, I want to do this without, but does give them an out. Every once in a while I have patients that, even though it seems like they are frustrated having family there, really want the family there. And if it's interfering enough, you have to be kind of thoughtful and creative about it, I guess. But I do think it's important to respect the individual's wishes of who's in the room with them. And so that's how I would approach it. Would be more of, I would like to talk to you alone for a minute. Can we do that? And 99% of the time, they're going to say yes. And generally, my experience is that's when you get the best engagement of the individual. Sometimes they'll say, no, I really want mom in. And then my approach to that would be, essentially stating what we're experiencing. Say, like, I've heard a lot from mom. I really want to hear your experience with some of these things. So I really want to hear your answers. And so if I can ask mom to be quiet for a minute and allow you to answer and go from there, can be pretty effective. And sometimes that really helps. And especially when you've got a very overbearing parent that doesn't need to be as overbearing as they are. And we're not sure about that in this case. But in that case, sometimes when they see their child start to self-advocate, they'll become more comfortable. And I now have some people that are, used to come in with parents every time and now come in on their own, or their parent will sit in the waiting room and they'll, text him and say, hey, will you come back now? I have a question that I need your help with, kind of thing. So very good question. I'm seeing multiple comments up here. Okay, yeah, that one's, I'm going to leave.
Yeah, Michelle sort of said, I lean towards asking how they are most successful in sharing
Yes.
information. Some individuals prefer to write the information,
Yes.
and verbal communication can be stressful.
And I think that's really important. So when we think about this case and we think about pre-visit planning, had we had some pre-visit planning, had we had some knowledge of like what was coming in, asking him, what kind of accommodations might help him could be really helpful. Is it a communication thing that could help? And I was in a meeting recently where we were talking about communication barriers in healthcare. And one of the, I think it was an autistic individual that said that their words were, if you need an accommodation to get an accommodation, that's too many accommodations. And, what they were trying to say is like, if I have to communicate to you that I don't communicate well in this way, well, that's a huge barrier. And so how can we break down those barriers? We need to be asking somehow. We need to make it obvious for them that we're willing to work with them, whether that's something posted in the room, whether that's something when they check in, whether that's through your intake process like we do. Or can you provide a list and say, like, we're willing, when I go to my dentist, they've got this list of, oh, do you want the TV on? Do you want this? Do you want this? Now, I've never been to a doctor's office that does that, but I want to do that in my office. Like, here's our list of options for you, So moving on. So, go ahead.
Before you move on, what about having to get the legal signature that they want the mother in the room or they want the mother out of the room, the HIPAA forms that we have on the adult side that people feel pretty strongly about? Do you use that, or how do you finesse that?
I always, at the first visit with my patients that are adults, explain to them that they get to choose who's in the room with them. And I will respect their decision. And especially if they got someone and then I'm moving to a more sensitive topic, I'll say, like, I want to ask you about something sensitive. Do you still want mom in here? I don't have any specific forms for during an office visit. If the patient is there and able to communicate, then they can consent, and they don't need a written consent for me to, feel comfortable. The tricky part is the in-between visit time, right? When you've got, someone, people messaging you through your patient portal or calling the office that are not, if it's not the individual, not the patient, and a mom or a dad or a, brother or whatever calls in, can I share information with them? And so that's where I think that's when you need to start asking them to sign HIPAA release forms and stuff like that. But if they're in the room with you.
Well, similarly, parents are often kicked off of portals.
Sure,
so they cannot get the information.
That is true, but then some parents get their kids logins and send me messages, and I have to decide, am I willing to engage in this conversation with that parent? And so I need clarity from the individual. Or sometimes parents call the office and say, so-and-so is not doing well, will you adjust his medicines? And I have to say, I need him involved in that conversation before I'm willing to, do anything like that.
Great, Tori.
I'm wondering how often you would see a patient like this. So this is your established care visit. When do you bring them back?
Well, it depends on the patient, right? It's really variable. I think there are times that frequent visits early on makes a big difference in helping people feel comfortable. So if you were to dig in with this patient and, as we think through some of the stuff on the kind of these different rubric questions of how do you make him feel comfortable? All right. So we discover that he's really anxious because seeing doctors makes him anxious. Well, that's a different thing that if we discover, wow, he really just hates, the lighting in the room, or there's a buzzing sound, or there's a kid crying down the hall, which happens in my office all the time, then how can we plan around that? But I don't bring people into the office just to like hang out with them. I'm sure none of you guys do either. So if it's variable, I have patients that show up and after their first visit, I see them back in a year. I have patients that show up and I see them in a month. This one, it kind of would depend on what we dig into, and we really don't have a lot of his opinion of his medical history yet, which we're not going to get during this case session. but I mean, it would be reasonable to us. My normal approach is let's bring you back frequently early on to develop a relationship, and then space that out over time is the more careful way to answer that, I guess. I think,
Great.
to hit on some of these other things, patience, am I out of time? Is that what you're saying?
No, no, no,
Okay.
no, no, no.
Let me comment
you're
on a
doing
couple other
great.
things.
Keep going.
So we talked about, mom in the room versus out of the room. That can be a progressive thing too. I think the other things to think about for this kind of person is, he seemed very anxious about like what's next, which is really common in the autism or intellectual disability population of not really knowing, especially when you're coming to a new place, being stressed, right? And so can you provide them some sort of guidance of like, here's our typical flow. For each of our offices, we have a social story with pictures and a description of like, step 1, step 2, step 3, this is the whole way through the office, of what you're going to experience. And for some people that's really meaningful, and some of them even will be like flipping page to page or saying first this, then this, then this, as we walk through them. And then always, I think at the end of a visit, pausing, especially if it didn't go as well as you want, and thinking about like, gosh, well, what can we do next time? And sometimes that's something you need to do with your team in the office. And sometimes that's involving the patient. And so you say like, well, we had some success, but we still have some things to work on. Going to what Tori asked, like, let's bring you back in a month and just kind of keep building on what we know about each other until we feel more comfortable. Any other comments or questions on this one?
Heidi, I didn't know if you wanted to make a comment. You put something in the chat.
I just think sometimes, even though these visits to establish care seems broad, that it's helpful to know the specific desire or goal for that appointment.
Yep.
And I find it interesting when it is different. The mom has a goal of suspecting he wasn't on his medication and wanting you to talk about that. And he knows that and is avoiding it, or some other whole different thing. But I think then you can use that time more wisely, and maybe they both feel satisfied with the appointment and you've established a little more of a relationship. I don't know.
Yeah, I think you're right. Figuring out what those agendas are is really important, especially when they're different between two people that are both engaged. I can't tell you how many visits I've had where it was the first visit and the patient comes in, or, with a parent, and the parent is like, we're bringing you here because this is the autism place, right? This is where you're going to, and the patient is like, I don't want to be somewhere where autism is an important part of my visit. Like, I want that to be like, and so I have to discover that so that I can then have the conversation like, look, half the patients I see in this office are not on the spectrum. You probably saw babies and, elderly people out in the waiting room, and really what I'm here is to do is address your priorities. And I personally, if I sense the tension like we did in this group, and if, the individual wants to leave parents in the room, if I can get the patient to say what their agenda is, that's where I'm going to focus my time. I really sideline parents' agenda, and that's you can make your own decision on that. But that is my personal approach. Is my goal is to make a relationship with the individual, and then figure out how I can incorporate the parent rather than the other way around.
So it'd be really nice if this was a new patient to you and had been followed by somebody, that they actually gave you that information in transferring the records of some sort. I think that's, there's the medical piece, but then there's also the piece that's always nice about the preference of the patient or the family that they want to pass on to you as a new provider. Now, I know it doesn't happen all the time, but that's just a general message about passing on records from pediatric to adult providers.
And I can tell you again, because our audience is from so many backgrounds, that sometimes comes from the pediatric provider, but I've had patients show up with a school teacher. I've had patients show up with their Board of Developmental Disability Service Coordinator. I've had patients show up with, a variety of other support personnel who provide that type of information for us. And so, yes, the standard is, oh, I'm a doctor, I want to get information from a doctor, but a lot of this stuff is really known by someone else. And that team, it depends on the individual and what their team is, but yes, reaching, if this patient were to have come and you're like, gosh, I'm missing something here, then you need to figure out where you're going to get that information.
Great. I think we do have to move on. Wait a minute, there's one more message here.
Yes, so it says that's the drawback of virtual visits with nonverbal folks. And I 100% agree with that is, and actually, quite honestly, with verbal folks that have heavily involved parents, is sometimes you're not sure if you're truly sometimes they're great, but also I've had times where, I get 5 or 10 seconds of a view of the patient, and then they move back to themselves to talk to me. Or it's really hard to know if a patient's alone and comfortable talking about private things on a telehealth visit. You never know who's outside of that screen. And even if you ask them, like, do you feel comfortable talking about this? I still sometimes see them kind of looking around the door and wondering who's hearing. So I think telehealth is hugely beneficial, but also not always the answer.
Yes, I've had young people go into the car. They've
Yep.
left the room and gotten into their car and talked.
Absolutely.
Anyway, we have to move on to case
Yes.
3. These are great cases, Chris. Thank you.
All right, case 3. So Layla is a 23-year-old with Down syndrome, presents to your office as a new patient. She's accompanied by her mother, who has a nice organized binder with all the documents, her medical history, her medication list, copies of her school's IEP, her individualized service plan from the board of DD. She's sitting there, Layla's calmly sitting there in a chair with her iPad, watching Dora the Explorer with headphones on. She makes some non-word vocalizations and has some echolalia, kind of copying what's said, but doesn't really reply to your questions. No reciprocal language. Her mother provides all the answers about her medical history. So then, you get through the history, and you get up and try to examine her, and she starts getting really anxious, and she won't sit on the exam table. Her mom explains she doesn't like the paper on the table, so you remove it, and then she gets up on the exam table. And as you start talking through stuff, you realize, wow, she's due for a lot of stuff. She hasn't had a lot of preventative care. She needs a tetanus shot. She needs some labs. She needs a pap smear, which has never even been discussed before. But as soon as you mention a vaccine or a shot, she says no, gets up and tries to run out the door, runs down the hall, trying to leave the building. Takes several minutes to kind of corral her back into the room, and she remains visually agitated. So here we are. We thought things were going well, and we mentioned a shot, and boom, we've lost. And so let's start by kind of talking about pre-visit planning on this one then. What do you wish you would have had, or what would you like to have for future knowledge for future visits for this patient to plan? And some of this cycles back to things we've already talked about, right? I never clarified in that case, is mom guardian, or does mom have some sort of formalized supportive decision-making document? If not, we should probably be exploring that question, right? What else? We have the exam paper problem. This is something I've had. I have a patient that will not sit on that exam paper, but if I take it back, they'll happily let me do everything. So understanding what will and will not work, and knowing those kind of things ahead of time, and knowing, hey, if you mention a shot, she's done, makes a big difference. Sometimes just the words you use. I have a patient that if I say thank you, will yell at me and leave. It's really hard not to say thank you. I have a sticky note on that chart that says, don't say thank you. I have to look at it every time before I walk in the room. So those are the kind of things that can really make a difference for these visits. Now, obviously, at some point, you have to address that vaccine question, right? You can't pretend like, oh, well, we can't talk about this, so we're just never going to do it. That's not good care. But goal number one is, let's plan for, like, what are we going to do to get them comfortable here first? Build on that, kind of progress through, how do we, what goals are we going to prioritize, and decide, like, all right, what's next? So realistically, you're not going to get vaccines, labs, pap smear, and whatever else done in one visit. And so for this patient, we're going to start thinking through, and this is where, you know, some of the conversations we had earlier, this is where we're going to start digging into how do we desensitize? How do we build up comfort for these things? And recognize that a lot of this comes from things that we as healthcare providers or as caregivers in other settings have done to these individuals in the past. Why is someone so freaked out about the word shot? Probably because when they got shots in the past, someone locked them down and stuck a needle in them. If someone held me down and put a needle in me, I'd be pretty angry about it and not want to go back too. And so we, and I please feel free to hop on and ask questions. I'm just going to talk about a few things we've done that have been somewhat successful, and I'm happy to answer questions and talk more about this case. But one of the things we incorporated early on when we started seeing this is what we called happy visits. And it's kind of a silly name, but essentially we would bring people in for deconditioning experiences, right? So as an example, a blood draw, we made a video that they could watch online that talks them through the entire process of what's going to happen. And then we bring them in and we say, like, all right, let's see what happens. And we get all the stuff out, and you look at them, you clean their elbow, you put a tourniquet on, and they freak out. Okay, done. You take it off and you send them home. And then the next time you bring them back a week later or whenever, and you do it again. And this time she lets me get the tourniquet on and look for a minute. Okay. And if I'm honest, this isn't me. This is my nurses and medical assistants. Let's be clear about who's doing the work here. And progress and progress. And many times we were able to get to where the patient would calmly sit there, let us put a tourniquet on, clean the area, stick a needle in, do what we need to do, leave. So more than half the patients that were a hard no, there's no way we're doing this, we got to where it was like, oh, hey, we can do this. And it was a non-traumatic experience for them. And so the next time they came in, it was like, sure, let's do this. Because the reality is a blood draw doesn't hurt that much, really, but the anxiety about it is the problem. So I do think there's a lot of role for deconditioning. But I said that more than half accomplished this. I have some that we brought in 10 and 15 times, and they would let us do everything up to the point of that needle. I've got a patient that we diagnosed with diabetes, and I put him on medicine, and then he refused to let us do a finger stick or a blood draw for 5 years. That's really uncomfortable. And we got it, so we have to strategize other ways to get that done for him, and we can talk about that if you guys want. But so there are some that you're not going to get there, but many you can get there. And quite honestly, half the patients that family says to me, you're never going to get a blood draw or a vaccine in that person, the first time we try it happens with no issues. And it's not because we're holding them down. We will not hold anyone down. We will not force anyone, because if you do that, you're putting yourself in danger, right? If you've got a needle and someone's getting angry, you're putting that needle away, walk away. But so you build on that, you progress on that, you work towards goals, you accomplish one goal, and then you move on to the next one. And then you have to kind of sustain those things.
Someone has a good question.
Okay.
How did you develop your interest in developmental disabilities? What can you do to get adult clinicians on board?
Sure. Boy, how do I answer that quickly? I kind of fell into it, if I'm honest. It wasn't like, oh, this is where I'm going. But as a med-peds physician, I saw that there were lots of people that struggled in healthcare as they moved into the adult setting. And one of those was developmental disabilities. And it was a population I enjoyed working with. And so I was looking for opportunities, and was lucky enough to get funding to support this program and kind of build it. Finding more people has been not as easy as I wish it was. As you all might imagine, this isn't a glamorous job in many cases. I love it. We have been lucky lately. We've started approaching pretty much everyone that joins our group, and that's both med-peds, and I continue to target other people, the internal medicine docs and people like that, to find people. And many people are, I've had a decent luck in getting people interested. We have 7 or 8 docs, with another one joining next year, that all are doing this as part of their patient panel. None of us are 100% full-time, this population in our group. There are places that do that.
There's another one here, another question. Did you Can you see
Yeah.
it
Do you
in
work
the-
with patients who have more involved IDD or guardianship and advocacy because their vulnerability isn't an option? Yes. How do you engage with those families for the best patient outcomes? So I think this is a really important question. So this third case would probably fall in that category, and the first case too, honestly, of someone who may not be in a position to self-advocate at all. And working with their families is hugely important. So if we talk about, this case 3 that we just talked about, having that conversation about, well, where are our priorities and goals? So I want to do all these things. What's first? What's second? That's a shared decision process of a conversation, and listening to them and hearing what they want. And that, but also I think there's a careful balance of these people deserve just as high level care as anyone else, right? So if I would give this vaccine to an individual without an intellectual disability, I should be giving it to the one with intellectual disability. But if there's a barrier to that, I need to explore what that means for them and understand their perspective on it. And so the pap smear is an example, which, this is kind of going down a bit of a rabbit hole, but if you dig into the literature on that and the data, if this person truly has never been sexually active, their risk for cervical cancer is lower than those that have been sexually active. Does that mean I shouldn't offer them cervical cancer screening? Absolutely not. I should offer them. But if they ultimately choose that doesn't make sense for them, I'm not going to fight them on that. If they choose they really want it and we can't accomplish it in the setting, then I'm going to find a gynecologist that's willing to take them to the operating room and get it done. Or, so it's variable. And yes, the Don, thank you. You are right that many of them have been sexually assaulted. And that is a really important consideration. And I that is part of every conversation I have about that, is that we know that we don't know everything that happens, especially those that are not able to report. This is complicated. I'm not saying it's not. So I'm kind of rambling. Let me look at my notes for a second and see what else I wanted to say.
Well, there was another question here, which is always the issue of if you're a primary care internist or, and how can you really do this at the level you're suggesting? And only a small percentage of your patients are, and this is hard because it does take extra work and extra training. So do you have thoughts on that? And then
I have lots of thoughts on that. It is hard. If we're honest, I do 3 times as much paperwork as my partners that do not care for this population. I get way more forms to sign, way more paperwork. That's a burden that I don't appreciate. Once patients get established and kind of settled in, my personal experience is most of them don't require extra time. In fact, many of them want to get out of that room as quick as they can. But and so I don't, early on when we started this, I scheduled extra time for every patient that had a developmental disability. I was booking an extra 20 minutes per appointment for them. I still book extra time for their new visits, their first visit with us, because I think there's so much complexity in the, both the communication and the kind of needs. But I do not have extra time for my follow-up visits. I have 20-minute standard visits and 40 minutes for physicals, which is a fairly common structure in primary care. And that's how I work it. Does that mean I might have to bring them back more frequently if I'm not able to accomplish everything? Sometimes. But also we all know that you look at certain people on your patient schedule and say, like, that one needs more time. So I book them for more time, on the follow-up visits. Question, do I have care coordinators, care managers to support new visits? Yes. So this is, I didn't talk much about our team structure, and that's really important. Because I have some external funding, I do have a full-time nurse that's a care coordinator that her job is to do intakes and just to help kind of manage stuff. If I've got a patient that's going in for sedated dental care, she'll coordinate and make sure they can get their labs and whatever vaccines we can do and things like that at the same time. We have a social worker that's specific to our population that helps with connection to resources, and a lot of outreach. And otherwise I use our general office staff, so our, medical assistants and registration staff and our triage nurses, that kind of work for the whole general population, do all this for us. Some of them come in with a lot of experience with for this population, some of them don't. What I found is once they start doing it, though, they quickly figure out this really isn't all that different than the other patients they're caring for. There's just some slightly different questions. And one of the nice things that happened, so I mentioned briefly, the concept of we have this room immediately process where a patient, that is not going to do well in a waiting room, we bypass the waiting room and stick them into an exam room to wait for the doctor. What happened after we'd done that for a while is a patient shows up that we weren't anticipating would have a problem, but in the waiting room, they're a little bit agitated and the front desk notices it. They just guide them straight back to a room and say, hey, we put them in room 7, and so we empowered them. And the same with my nurses, or the medical assistants, they've developed this comfort and they've kind of learned a process. And early on, I had several come up to me scared to death that became some of the best people to ever work with these patients. And so really it's about creating, allowing them to be safe, but also telling them, as I said in that first case, I tell every single person that works with me, if you ever walk in a room and you feel unsafe, you walk out of the room. I would rather you walk out safe and let the patient come back another time. So that's a long way of answering that question, but I think it helps to have the extra support. Absolutely. Does it, and we care for huge numbers. I mean, I myself have 400 or 500 patients on the autism spectrum on my patient panel, but I do think a lot of these patients can function within a fairly typical healthcare setting.
So we need to wrap it up. Chris, you've been fantastic. I think you have 1 or 2 more slides and we'll
Sure.
turn it back to Tori to wrap up the session.
If my slides will advance, there we go. Okay. So I think a couple important things, and this is kind of a summary of some things on the tip sheet that I mentioned at the beginning with Got Transition that you can find on their website. But if you're planning for this, think about doing a lunch and learn or an in-service. Try and find that office champion to help guide your efforts. And then plan a walkthrough with a patient or two, whether they're in a wheelchair, whether it's someone that may experience sensory experiences or things like that. And look around and find those other supports. The reality is a lot of the supports come through, state resources. And then you just kind of got to build and grow, quality improvement mindset of like, oh, what worked, what didn't, let's iteratively improve on this. And I think if you take nothing else away from this, I hope you take some of these key points. And I didn't really highlight this as much as I should have, but behavior, whether it's aggressive behavior or whether it's the teenager laying back with his phone or whatever, is the way they're communicating to you. And so paying attention to that behavior and recognizing that if it's a new behavior, maybe it means something. Ending encounters on a positive if possible. As I mentioned, those happy visits or whatever it is, finding a way to let them leave feeling like they succeeded is really important so that the next time they come back, they're less anxious. You have to be creative. Every site we work at required different solutions and a lot of feedback. And if you do that, I think this is a group that can get better care.
Chris, thank you so much. Obviously, you've taught us a lot in these 3 cases, and I think Tori also put the links to those 2 form in the chat. And I'll turn it back to Tori to wrap up.
Excellent. Well, thank you, Dr. Hanks. This was fantastic. I learned a ton and have so many ideas. So I think Katie will pull up our slides, but thank you everyone for coming. A few quick announcements. One, we would love real live cases to talk through, and much like Dr. Hanks presented here of kind of what can we learn from each other on those cases and to help you get support with the questions you have. So that's number 1. Number 2, we want your feedback on how we can make these echo sessions more useful, more effective. I think Katie put the link in the chat to the evaluation. You'll also get an email with that as well. Thirdly, we are all set to have our 2nd annual Minnesota Healthcare Transition Summit, which will be happening in St. Cloud at the Convention Center and Holiday Inn, right there by the river. It is June 13th. There will be both an in-person session as well as virtual option for everyone to attend. We will continue our journey of bringing experts from outside of Minnesota to help us in kind of bringing additional knowledge to our state, as well as including some partners from within the state as well. Katie put the registration for that event in the chat as well. Today's session was recorded. Please share with your colleagues to give them ideas for the future. And we're just so thankful that you're here. And thanks again to Minnesota Department of Health and COPIC for their funding. Have a wonderful month. We'll see you in March. Or sorry,
Take care.
March. We'll see you in April.